Hi there, everyone. Thank you for joining us for today's program, Vaccines 101 for Campus Communities, which is being offered in partnership between ACUHO-I and ACHA. My name is Holly Stapleton. I serve as COO for ACUHO-I, and I'll be moderating today's discussion. Our hope for our time together is that this is informative and collaborative. With this in mind, we hope that you'll actively participate by submitting questions, comments, and responses in the chat along the way if you're moved to do so. This session is being recorded, but we will also stop recording towards the end to facilitate questions in real time. In advance, I'd like to thank ACHA for working with us on this program and convincing members of their amazing Vaccine-Preventable Disease Committee to offer their time and talents for the program. I'm sure you all will be as impressed with this thoughtful group as I have been. A big thank you to our panelists. With that, let's move to some quick introductions. We'll ask each panelist to state their name, title, and give us a little bit of context around their role on campus. Dr. Chang, do you want to start us off?
Sure. Thank you so much, Holly, and thank you all for your participation. I'm sure you're all very busy. I'm the medical director at the Student Health Center at UC, so University of California in Irvine, that's in Southern California. I've been here almost 10 years, and it's just been a remarkable experience for me as a pediatrician moving into student health and looking into opportunities to serve our very unique population. Thanks.
Great.
Hi, everyone. Thanks, Holly. My name is Barb Flutie. I am a PA, and I am the Director of Student Health Services here at Hamilton College. We are located in central New York, kind of nestled between Syracuse and Albany, for those that are familiar. My background was 15 years in family medicine before I came to College Health, and I've been here for about 14 years now. And I'm excited to connect with everyone today.
Hi, everyone. I'm Emily Lenz. I'm a nurse practitioner and the director of health services at the School of the Art Institute of Chicago. And I've been here about 13 years and do all things vaccines.
Hi, I'm JoLynn Montgomery. I am an infectious disease epidemiologist at the University of Michigan, and I run all the public health activities on our campus. So we have a population of about 50,000 students, so it's a big group. And our students, we find, love to share. So vaccine-preventable diseases are of particular interest to me because students like to share so many things.
Excellent. Thank you so much. And if we could advance really quick, a disclaimer here about content and communications that we want to offer for this particular program. Certainly these are amazing experts, but this is not advice or counsel. So please take that into consideration as you view the program. To get started, we wanted to get a sense of who's in the room. We know this is a mixture of housing folks as well as other administrators and other professionals on campus. So we're going to do a quick poll here to get a sense of who's in the room. All right, we're squeaking up here. We're at 90%. 93. All right, so we'll just see what we got going on. Looks like the majority in the room are campus health professionals, some folks at the upper echelons of housing, and then some other folks working on campus, which is great. That kind of crowd will help us have a really dynamic conversation. Thank you for responding to that. Okay, so to kick us off here, we want to do a little bit of a level setting prompt. We're obviously all working and living in a time where vaccination requirements are dynamic and vary significantly by geography and various policies. So if you could please reply in the chat in just a few words, how would you describe the current environment for vaccines and vaccine acceptance on your particular campus? That would be great. Give you a couple minutes to do that. All right. and some looks like compliance is generally good, support from upper administration. State laws are coming in here in terms of having an impact. Some vaccine hesitance, it looks like. Interesting. Some exemptions and an uptick of exemptions moving forward, which feels kind of appropriate given the times. So thank you for sharing those pieces. That helps us know what we're responding to today. Robin, if you want to advance, that'd be great. And we will pass to Jolynn.
Awesome. Thanks, Holly. This is really exciting to be here with you all today. Robin, if you could advance the slide, please. I want to start with a history lesson. I promise it'll be really short. But we really got going in vaccines during World War II. Our military personnel were very concerned about, frankly, the 1918 flu pandemic and the impact that that had on soldiers. And so they wanted to they decided to start developing and researching vaccines or a way to keep that from happening. A lot of that work actually happened right at the University of Michigan. This is a picture of Thomas Francis. He's standing in the middle, and he really was instrumental in developing that flu vaccine. And he worked very closely with Jonas Salk, who is not in this picture, but was a postdoc in his lab, developing the polio vaccine and doing some trials to see if those vaccines worked. So the vaccine development efforts were really important coming out, or really during World War II and then coming out of it. And the focus of these has been mostly on vaccines that have sort of outbreak or epidemic potential. So these are diseases that can spread pretty quickly to a lot of people. So I've just highlighted a few here. And just for information, I purposely left COVID off of this list because COVID's a little bit strange, and we're just going to ignore that one for right now. Happy to entertain questions about it if that comes up, but focusing really on a couple like measles and meningitis in this talk. Now, most of these diseases either spread through the air very easily, or they spread through close contact, like sharing utensils and cups and beverages when you drink out of the same cup. And obviously, we've got a lot of that going on with our student population. Next slide, please. Because our students are kind of different than the rest of the population. They have bigger social networks. They're a young, pretty healthy overall age. But they live in these close, tight settings, this congregate living, which is kind of similar to a military barracks when you think about that history lesson we just talked about. They're transient. They move around a lot. They travel a lot. And whether that's traveling internationally, which we have some students who do that. We have a lot of international students, and they, may go home for holidays and summer breaks and that sort of thing. But also just traveling state to state and town to town. Students travel a lot. They act differently. They have different risk behaviors. Student populations are just different. You guys all know this. I'm definitely not telling you anything you don't know. But that means they're at different risk for a lot of these diseases. So vaccines are really important in college settings because of the way these diseases can spread and the types of behaviors that are just part of many college experiences like that congregate living. Next slide, please. So roughly, do you guys have a concept of what percentage of your student population is fully vaccinated against measles? Now, is this a poll, Holly? I'm sorry, I can't remember. Or just an answer in the chat.
This is a poll that will hopefully be working
Oh,
momentarily.
Cool. Awesome.
All right. Here we go. Okay, we're at 85%, we're going to go for it here.
Fantastic. Oh, pretty high level of people knowing that their population is 90% or more of their population is vaccinated. That's amazing. A lot of people unsure. It's pretty cool. So if we go to the next slide, please. Why would we want to know, and how would you even know? So this is actually data from last year from the University of Michigan. We just really closely track our students in housing, but about 97% of our first year students live in housing. And so if we're thinking, I'm going to focus just right now for a few minutes on measles vaccine. That's one that is a single, you get 2 doses. You don't need vaccine as an adult after you've had it as a child. So once you've had it, you've had it. So it's a really easy one to think about in these situations. Now, if you look at all of our students in housing, we're just below 92% vaccination coverage. And if you look at just our undergrads, we're about close to 97%. The reason I think our sort of graduate students have a lower proportion is because a lot of them are older and they don't frankly have access as easily to their documentation. And at the University of Michigan, we require that if they live in housing, they have to submit their vaccination records. They don't actually have to have any vaccines. They just have to tell us what they do or don't have. So it's really useful to know that kind of thing. And one of the reasons is because you can kind of predict what would happen. Now, in order to prevent a big measles outbreak on a campus, you want about 95%. That's your goal, 95% of your population to be vaccinated for measles. So I just wanted to show you, if we could go to the next slide, you're going to see a website that you'll be able to access and play with. But it's a predictor to show what would happen and how far measles would spread based on our 2 levels in our undergraduate population, 97%, 92% in our whole housing population. And then I threw in 73% because I just thought that was a fun number to play with. Again, our goal is 95. So you'll have access to this link. I chose a population of 20,000 students just to play with. Again, you can set that for your different campus size. So next slide, please. So if you've got 97% of your population vaccinated for measles and you have 1 case of measles on campus, it's really not likely to spread. So you can see here on the top left, that's actually 20,000, not 2,000 with the school enrollment. We had 1 student initially infected, just showing you how to set this up for yourself and the vaccination rate. And then you can interpret this by this graph that has the days on the x-axis, the bottom, and that's just how long it will take for this to play out. And then the number of infected students on the y-axis or the side. So you can see you started with 1 person. This shows sort of 20 possibilities, and then the blue line is really what we're focusing on. That's kind of the most likely scenario. So what we're seeing with 1 case and 97% vaccination coverage, maybe you'll get another case, but maybe not. It's not likely to spread very far. We're talking 1 or 2 cases here. Next slide. If we drop that vaccination coverage to 92%, all the parameters, the other parameters are the same. You can see that, well, you might get a few more cases. In the early days, you might have 1 or 2 cases. You can see at the sort of bottom left of that graph. But as you go on, some of these gray models show that, wow, we might have 70 people who are infected. It could grow if the population that 1 infected student is around happens to be that 1 population that's not vaccinated. But likely our numbers still are going to be relatively small. Next slide. Now, if we drop to 73%, that's when everything breaks loose. We really see first few days, it takes a while. Measles takes a couple of weeks before infection shows up. So this is a little bit slow as it increases, but we're talking 2,000 cases after about 2 months. And what that means is 10% of your population might develop measles. We know that people can get pretty sick from measles. I know Dr. Chang's going to talk a little bit about that, so I won't go into that, but it can spread pretty far, and it's not instantaneous. It does take a few weeks, so that impact will definitely take a little bit of time to show up. If we can go to the next slide. You can see here that I wanted to show you sort of historically what's going on in the United States. And since 1985, we have clearly made great progress in controlling measles. You can see this time from 1995 to 2025. Those case numbers are really low for the whole United States. But back in the late 1980s, early 1990s, we had measles was pretty common. In 1989, they recommended, and by they, I mean the CDC, recommended that we do a second dose of measles vaccine. And then, of course, adopting that practice actually took a little bit of time, but relatively rapidly, within a couple of years, we completely had measles under control in this country. It was pretty astonishing how that second dose of measles vaccine impacted the country. Without further ado, I'm going to introduce Dr. Chang, who's going to tell you all about the great stuff.
Thank you so much, Jolynn, and just wonderful information. We're so lucky to have you kind of on our team here. We've got quite a variety of different specialists from different areas, and so really bringing it all together. And, we're going to have a little bit of overlap in some of our conversations, but I wanted to share, our situation here at UC Irvine. So we've got about 35,000 students on campus. They're all required to have insurance, but not all of them need to have our campus insurance. About 60 to 70% have our plans. So it's about 22,000 students. And so those are the ones that we as the health professionals on campus have at least access to and visibility to more closely than the other remaining 30 to 40%. So they'll come in, we'll treat them as our patients. And so we can definitely manage and control infections and spread and communicate with our partners across campus and housing specifically. I bring this up because the other percentage that doesn't have us as their healthcare providers, it may be a bit more challenging. So they may have outside PCPs, they may go to other clinics, and they may not alert all of you about what's kind of going on with as far as their personal health. They might not be within the system. And so we do our best to kind of work with partners to help identify some of those concerns as they do pop up on our campus so that we can kind of stay on top of it when there's a very variety of access to care through different medical partners. Next slide, please. So a lot of what Jolynn spoke about is kind of my intro slide here too. So, why does it matter to us on our campuses? And just, coming from a pediatric population to now a campus health population, we're like the hotbed of spread of infection because of just the nature of what we do. I'm having students living within the hundreds or thousands in large housing complexes, in classrooms, in gymnasiums, in cafeterias, and libraries. And as Jolynn mentions, their behaviors are putting them at risk. So it's really important that we take a focus on this, but also it gives us a strong opportunity to kind of catch our patients, our student population as they're at this stage. So I mentioned before that I'm a pediatrician. And when I came into student health, I knew that I was giving up seeing the newborns, the little ones, like the K through 12s, and I miss them like crazy. But this is like pediatrics 2.0 for me, because looking at all the work we did as pediatricians, nurses, teachers, parents, how good of a job did we do in raising our children to become productive, responsible young adults? And we're seeing it now. And we did a pretty good job overall, but this is that chance to really plant those few nuggets of information, get them protected. This is like that K through 12 safety net, catching anything that kind of slipped through the cracks and really protecting our students as they go on with their lives, ensuring that they've got that success. And one of the key things for me, for all of our students, they're on campus for one reason. It's for their education, it's for the academics, and they're in a mindset of learning. So if you can plant these seeds while they're still relatively like impressionable, so they haven't, they're not in their 30s yet where they know it all, they're not going to take information, they're still looking for more information. You can empower them to practice healthy behaviors, to understand concepts in health that will impact their own personal lives, their partners, their families, and it goes generationally. So I think this is why I'm passionate about student health, and this is why it matters to us on campus, not just vaccinations, but healthy living overall. Jolynn spoke about some of the infections that are kind of higher risk for us. There's a variety of different policies and mandates that are on different campuses. Typically, it's the ones that are spread by kind of airborne, cough and cold. And the one, I will talk a little bit about COVID simply because COVID was the big eye opener to all of us as a planet about what we should be doing, what we could be doing to improve our infection control. And then even now in the aftermath, how we want to stay smart about things. And I'll speak a little bit about a study that we did on campus in a little bit. For us as healthcare providers and healthcare professionals, and it sounds like many of you are, the consequences are high. So serious illness to our patients, to our students, to our own staff, to our faculty. During COVID, I'm going to knock on wood. We were pretty lucky in that our young student population they were infected, but they weren't being as impacted as far as hospitalizations and complications. But our faculty and our older staff members, they were the ones that were truly suffering. So we're lucky in some ways, but serious illness is always that big risk. So hospitalization, fatalities, and then just campus disruption as a whole. And then in the bigger picture of things, reputations as a campus, financial impact of kind of stopping things and moving forward, or having to change efforts to catch up on what we may have been preventing in the first place. Next slide. So I'm going to speak a little bit about meningitis. I'm fortunate in that our provost here at UC Irvine, after COVID had started to settle down, so 2 years ago in 2023, thought, let's be prepared for that next big thing. So we did a campus-wide tabletop exercise looking at meningitis B if an outbreak was to occur. And one of the reasons we did this is because meningitis is one of those infectious diseases that targets populations just like our campuses. And this is just a quick slide showing that meningitis, although relatively uncommon out in the general community, does target certain populations. So if you look at the universities that are here, so one of them was one of our sister campuses, UC Santa Barbara. And when they went through their challenges, we, as all of our UCs, kind of opened our eyes and said, okay, learning from what's happened at their campus, this is our opportunity to be prepared for that next step. And this, the tabletop plan that we did involved not just the student health centers, housing for sure, academics, environmental health and safety, dining halls, recreation, and we've reached out to community partners as well. So a huge part in all of this is our public health departments in our counties and our communities. So if you haven't already, reaching out to them, because when something does happen, they'll probably take the lead, but then we'll be close partners to enforce and enact what needs to be done to prevent spread. So I'm going to focus a little bit about meningitis because it's a bit of a special topic for us. Next slide. So similar to what Jolyn was mentioning, our students are just at higher risk. So meningitis itself spreads through close contact, all those things that we spoke about, close quarters, kissing and activities, smoking, sharing utensils, and then just infection across the board. Meningitis, you probably all know, it kind of gets the label of being so dangerous because the symptoms can come quickly. So in those 0 to 8 hours, just early signs and symptoms can be non-specific, very flu-like kind of infections. But within 9 to 15 hours, you start to get some of those classic meningitis signs. So neck pain and rigidity is very classic for that, as well as a rash. So kind of a purple splotchy rash that can spread. And then within 16 to 24 hours, it can progress very quickly to hospitalization and then worst cases, fatalities. Most likely now we'll catch this sooner than later, but depending on either the patient's knowledge of what's going on, sharing what's happening, access to care, these can become very challenging. And so this is one that we kind of try to keep top of mind when we're talking about infections. Next slide, please. So spreading through our residences again, it's just, there's really no way to prevent it. There are so many risks that Jolyn also mentioned about the close contact, the crowded housing, the activities, the school events, and this is what they came to campus for. Students are on campus to socialize. It's an essential part of their growth and development, in addition to their academics, right? Their socialization. And so it's tough when that aspect of their lives puts them at higher risk. And so this is why vaccines are so very important. What our partners in residence life can do is start to, we don't expect you to be clinicians, to diagnose, to treat, to do any of that. But you are a bit of our eyes and ears to what's going on in those communities, because students are living in your facilities 24/7. And you can let us know, or oftentimes, share with us anything that's coming up. So noticing clusters of students, maybe 3 to 4 students, or whatever's happening on the floors that may be more important than a single diagnosis. I'll share that hand, foot, mouth became a thing a few years ago, and we kind of took an alert to it. We investigated a bit, and we were able to impart and share some preventive efforts to to keep students from spreading these type of infections, encouraging our students, our patients, to report things early and seek medical help and evaluation. This is where I think our resident assistants are critical. These are probably for especially our international students that have no idea about what our kind of US healthcare systems like. So reaching out to our RAs, and once again, not to diagnose, not to treat, but to share how to access that right level of care. And even if students don't have our insurance plan, we always encourage them to reach out to our student health center so that we can help them identify where that level of care can be. And that was that last point I put down there. Next slide, please. So once again, prevention is kind of the key when we're talking about spread. Like once it's happened, not that it's too late, but it's really difficult to kind of wrangle things up. Jolynn mentioned this kind of in her presentations, but for me, we have quite a few students that are immune compromised. We spoke about exemptions. So I review all of our medical exemptions, and there are legitimate cases where students should not be receiving these vaccines because of their own personal health situation, but they are the highest risk. And it truly is those individuals that we need to keep protecting. With their medical conditions, they deserve to be on campus. They've worked hard to be here. They want to experience everything. It's ensuring that they can experience in a safe and healthy environment. So knowing your campus policy is important. It was great to see that a lot of your numbers and your awareness about vaccines and its importance is just reassuring. Be aware of any campus programs. Like we at UC Irvine have a vaccine clinic that is kind of moving around campus. So if you can't get to us, we'll go out to you. So being aware of those access points, and then contacting us immediately if anything comes up. And then, residence life and student health, we are the 24/7 kind of disease surveillance for a campus. So clear communication, immediate communication, partnership, and working together is going to be the key moving forward. Next slide. And I'll pass it over to our strong partner here, Emily.
Thanks, Albert. Next slide, please. I'm going to talk a little bit more about how Res Life and health services or wellness center partnership can look. So residence life staff, as Albert said, play a role in the early detection of disease and communication to students. They hear from sick students and connect them to on and off campus healthcare providers. They communicate to residents when illnesses are common and could provide signage regarding healthy behaviors in common areas, if there's common restrooms, if there's just common areas, hand washing, how to cover your cough, things like that. We want to establish clear communication pathways and shared response protocols. So remember COVID and how things happened. I think a lot of us were kind of scrambling, but if you can think about that time and how can you make that better now so we're ready for the next time. So who to communicate with on your campus and when. So typically the health service would be a good place regardless, and we can figure that out. If it's after hours, are there on-call staff that you can reach out to. At SAIC, we have deans on call, and then they can connect with other people if as needed. And what do you need to do if a student shares that they have an infectious disease with you? Probably connect with health services to see what else needs to happen, but having those policies in place. At SAIC, we have both formal and informal methods of communication. The dean on call would be the more formal route, getting that person involved, either to talk to the student or to talk with other staff. And informally, Res Life staff will just G-chat me or email me and say, hey, we have this going on, what should we do? And that's all fine. We also want to make sure we protect our students and staff in housing, ensuring they feel safe and supported. So providing personal protective equipment to them, maybe masks, encouraging vaccines such as updated flu and COVID vaccines, making sure they're protecting themselves too, and providing information about disease transmission. So when is flu rising in your area? When is COVID rising? Making sure that they're aware of those trends that are happening too. There's a huge benefit to this relationship building before there's a crisis, which I think, again, we all learned during COVID. So having an established relationship with necessary departments makes it easier to communicate in a crisis. Maybe even just, having division-wide meetings if you're under the same division so that you're familiar with these people, with the other people, with the other professionals, so that when that crisis comes up, you know who to turn to. So I'm at a small campus. SAIC has about 32 to 3,300 students. We're pretty small. We're also urban. So we have campus buildings kind of sprinkled around downtown Chicago. And so we have vaccine requirements. So I communicate weekly with the Res Life team around who's compliant with the vaccines, who is not. They help with, putting notices under doors for students who are not compliant. So we have that working relationship. We have monthly meetings. We're in the same Department of Student Affairs. We have monthly meetings. So I know who that person is. So if something would happen on either end, we can work with them. So we are familiar with them and work on building these relationships over time. Next slide. And I'll pass it over to Barb.
Thanks, Emily. That was helpful. I'm going to be touching on vaccination policies, challenges, and partnerships. And mine is going to be similar to Emily in that it's from the lens of a small residential campus. There's about 2,000 students here at Hamilton College, and they all live on campus. They're all in residential housing. So it's a little bit different from some of the other folks. Next slide, please. For many campuses, the strongest vaccination policies have centered on measles, mumps, and meningococcal ACWY. However, not all campuses have vaccine mandates guiding them. As Albert had talked about earlier, some students cannot be vaccinated due to medical contraindications or immunocompromising conditions. And so for these vulnerable populations, high campus vaccination coverage is essential for community protection. And again, that was also mentioned by Jolynn when she was talking about the 95% goal with measles and looking to protect the community. As you'll hear throughout today's session, strong partnerships between residential life and health services are key to rapid outbreak response and to improving compliance with mandates. An efficient electronic health record with robust storage also will strengthen outbreak management. Following COVID-19, a survey published in the Journal of American College Health reported that only 35% of campuses changed policy following previous outbreaks. And for me, this really illustrated the complexity of campus policy development, as it often takes more than an outbreak to shape policy for most campuses, as was also touched on earlier by Dr. Chang. Next slide, please. So vaccine mandates are most effective when they're consistently enforced. Without consistent enforcement, they lose credibility. So support from colleagues outside of health services is critical. For those involved with compliance-related matters, external help can make or break success. And we have learned to rely on campus partners to support mandate compliance. For example, community living will place a temporary check-in hold on students who have not engaged with us before they arrived on campus. Once we know that we've got a documented plan to address this need, they get their keys. We fully staff the health center on the first day of orientation, so we're prepared to complete any missing items, be that MMR vaccines, Tdap, MenACWY, even TB testing. So we try to, really make sure we staff up so that we're prepared for the influx. Also, our international students director will reinforce our messaging and partners with us so that we can schedule services for international students the day before orientation. So we don't want to overwhelm them when they're here for that orientation experience. So we try to do things where we can and meet them in a better space so that it's less stressful for them. We've also partnered with the Dean of Students Office, and we're prepared, we haven't had to, but we're prepared to pursue conduct points for students that fail to comply with requirements after they've arrived on campus. Next slide, please. During outbreaks, quick, accurate data retrieval is essential for identifying who are vaccinated versus those who are not up to date. An EHR is only as good as the information entered. So with mandates, complete records for required vaccinations should be readily available. Many systems now interface with state immunization information systems, which can improve data completeness. However, challenges can arise with unexpected outbreaks involving non-required vaccines. For instance, managing a hepatitis A case at a small institution like mine required very extensive record review because hepatitis A was not being tracked within our EHR. So think about this being even more complex at a larger institution. So ensure that your team has the bandwidth for any new initiatives that you're going to undertake and support that. Next slide, please. Institutional support beyond health services is crucial. Partnerships with residential life and community living, along with the Dean of Students Office, enhance protection for the entire campus community. All campus colleagues share responsibility for reducing barriers to vaccination, and students should be actively referred to campus health centers for vaccination-related questions and services. The COVID-19 pandemic showed how fear and anxiety can accompany emerging infectious threats, and by embracing evidence-based vaccination practices and maintaining strong cross-campus partnerships, we can reduce the impact of vaccine-preventable diseases in our academic communities. Thank you. And I'm going to transition us back over to Dr. Chang in Montgomery.
Awesome. Thanks, Barb. Next slide, please. So I just want to talk for a second, and I'll be really quick because I want to make sure we leave time for questions. But I wanted to talk a little bit about what recommendations are. So when a vaccine gets approved, basically literally truckloads of information. I'm sure it now comes on some really fancy electronic device that's much smaller than truckloads, but previously literally truckloads of information would show up at the FDA from pharmaceutical companies where they'd done extensive testing of the vaccines, of whether they're safe and whether or not they work. And then the FDA reviews all of those piles of documentation and decides, yep, this is a vaccine that is safe and effective at preventing an illness. And then they move forward with approval. Many vaccines don't get that far. They might be started, the pharmaceutical company may stop research, FDA may not approve them, or they may go back and say, well, this looks pretty good, but we have more questions. So there's the time of back and forth. It takes years for most vaccines to get on the market. With COVID, it was very unique because we had an active emergency, but those vaccines had been under development. I don't know if you remember SARS back in 2003, 2002, but the vaccines we used for COVID started being developed 20 years before they were actually used. So vaccines are not a quick process. So after FDA approves a vaccine, then CDC and other health professional organizations review lots of information and say, yep, we are actually going to, not only is it legal, approved, licensed to have this vaccine, but we're going to recommend that it gets used in specific populations. So maybe that's young children, maybe that's older adults, maybe that's everybody. It varies vaccine to vaccine. So those are sort of national recommendations. The World Health Organization has a similar set of recommendations. Now then, state health departments also get involved in this and may make additional recommendations. So there's been a lot of confusing press lately about changes in vaccine recommendations and requirements. I'm going to talk about requirements in just a second. But frankly, very little has actually changed in terms of what is recommended that people get. Most vaccines are just out there, they're safe, they work, we know it, and most people actually get them, regardless of the press. Next slide, please. So then we have vaccine requirements, and vaccine requirements are just a level of protection. So they're kind of like a construction area where you got to wear a hard hat. They protect individuals from a specific hazard. Now, in some situations, like in healthcare settings, we require specific vaccines to protect not only that person who wears the hard hat, the healthcare worker, but also their patients, because vaccines actually work both ways. They protect the person who gets it and the person who they would potentially be able to transmit the disease to. If they don't get the disease, they can't spread it. Vaccine requirements can happen in the workplace. They can also happen, many states have K-12 school requirements for vaccines. In Michigan, we certainly do. And then some colleges and universities have their own set of requirements, and states have their own set of requirements. In Michigan, like I said, we have K-12 requirements. We do not have any university or college requirements for vaccines. But most of these, once they got them as a kid, they've still got them as a young adult. But these can vary a lot from place to place and institution to institution. So it's important to know what your institution requires, and then what counts as an exemption. So if you do have a requirement, sometimes we say, well, like Albert mentioned, they might really have a medical contraindication. They shouldn't get that vaccine for their own health reasons because perhaps they're allergic to an ingredient or have had a bad reaction in the past. There are also some exemptions that are religious. Some religions, although actually very few in the religious doctrine actually prohibit vaccination, but some people will use that as a reason. There are a couple of religions that do have doctrination of no vaccines. And then we have philosophical exemptions. And again, exemption options vary from place to place, state to state, institution to institution. So it's important to know what your situation is, or find a health professional. I bet your college health team knows exactly what those are. Albert, I'm going to leave it to you. Next slide.
Thanks so much, Joanne. So we've got a chat prompt here. So I know you've heard these. Okay, we've all heard these at this point. So what's one phrase or myth that you've heard about vaccines? I'll share a couple of decades as a healthcare provider. Anti-vax has kind of always been around. Vaccine hesitancy has always been around, but the internet made it explode in so many ways. Other perspectives, COVID made things explode in certain ways. I'm a bit concerned about how AI is going to market and message around things like vaccines and hesitant and false information. One of my biggest concerns is that, we as a society are losing faith in science and belief in science. We've got to make sure that's still there. Even if you're not a scientist, and for us as a scientist, more important that we're communicating to non-scientists, explaining in ways that are not alienating, but actually securing. So let's kind of look at some of these here. So vaccines can cause autism and infertility, of course. The flu shot gives me the flu. Your immune system will naturally fight it off. Big Pharma just wants our money. We don't know if they're safe, So this is an example of how confusing it can be. And I'll admit it, during COVID and like vaccine, I was a bit confused about the boosters and this and that, So if I'm confused as the medical director, imagine our students, imagine our faculty, imagine our staff. So that's why clear communications, being on top of it all, is critical. Next slide, please. So, we're all in positions to communicate information that hopefully people respect and will kind of listen to. So communicating information during this misinformation era is just so challenging. Like, I don't even know how students are getting their news these days. It's definitely online. It's not through the newspaper. Remember those things, right? It's not through the networks and TV. So what are we doing and how can we better communicate with Gen Z and the emerging Gen Alphas? So, this is for students, but truthfully, this works for anybody in respecting conversation. I've got some neighbors and relatives that aren't quite convinced, and so I want to make sure that they're understanding. So the trusted messenger effect, once again. So we as leaders are resident advisors. They are seen as kind of those key points to a worried incoming freshman. Student leaders, peer ambassadors, and I kind of focus on our students because hearing it from someone, from one of your peers, is sometimes more impactful. But then coaches that are involved with our students, coaches that are involved with learning, professors, we're all in these positions. So there's trust that's there. They may listen to it before they just go off of what this TikTok is telling them to believe or not believe. For us at our Student Health Center, making sure there's low barriers to access for these vaccinations. So we have a walk-in Monday through Friday, most Saturdays as well, no appointment needed, covered by your student fees very clearly. I mean, student fees is a big thing, right? These vaccines, if not covered, can be costly. So knowing how to get them covered, and programs that will help them get them covered is important. Using empathetic first language. So, it makes sense that you have questions. Can I share with you what I actually know about this? So avoiding the confrontation, avoiding the judgment when you know it's kind of driving you crazy on the back end over here, but opening the discussion and sharing with them that you care about how they're feeling and you want to get them to maybe a point of understanding. And then framing the vaccination as a self and community care. And that's critical for our campus population. So it's about protecting those that are around you. So even if your roommate is not, immune compromised, what are the risks of spreading this infection? What would you want not to receive from someone that's close to you? So these are roommates, teammates in athletics. I don't know what you all saw, but during COVID, there were a lot of teams, women's soccer, men's volleyball. They're all living together. They're doing things together. We will get these clusters. And so being sure not to spread it to those that are closest around you. And then, bringing it home. So Thanksgiving is right around the corner. All the people you'll see at home, all the people they'll be hugging and sharing utensils with, you don't want to bring anything home to your elderly family members, to your parents, to your nephews, nieces, anyone else. So keeping it protected. And speaking about that sometimes gets them to think out of this. This is just my decision for me, myself. Definitely what doesn't work, shaming, just dumping data, which may not make any sense, or just simply saying, just go get the shot, right? Um, forcing it, that's just going to push them the opposite direction, to tell you the truth. And then, as the medical director, just because the medical director says so, that's not necessarily a good thing to say either. I look at all of our medical exemptions as well as our religious belief exemptions, and a lot of it is just pushing against the mandates. So you're forcing me to do it, and our college students are at this point of kind of, resisting and pushing back against authority. And it's like, well, just because you want me to do it, I'm not going to do it. So get away from the forcing, go towards the education and open up that discussion once again as a trusted messenger. I think that's the way that we can all step forward to get understanding across our campuses here. Next slide. And I think we're kind of wrapping up here. And so one kind of final chat prompt before we go into our question and answer session. So what have you seen being done on your campus that works? So the good stuff. And then something that you're proud of regarding vaccines on your campus. And as we see the answers kind of popping up here. So yeah, the mobile clinics are great, right? If you can't come to us, we'll go to you. One of the things we've done is we've partnered with some of the local pharmacies during our busiest season because our student health center can't handle the capacity. So they'll pop up shop and it's great because they'll do their own scheduling, insurance checking, all these things. And they'll give vaccines to staff, faculty, anyone that's living on campus. It's not just limited to students. So engaging student workers to employees to kind of promote our services is huge. The Department of Health is critical to come and in providing services and support. The Protect Yourself and Others campaign. These are all great. This is great feedback. So keep up that strong work. So I'll go ahead and wrap up here. And Holly, will you take it for Q&As? Any questions that have popped up?
Yes, absolutely. Thank you, Dr. Chang and our panelists. I'm going to stop recording so we can have some real-time Q&A. But for the sake of the recording, thank you all for being here. The recording will be provided both through ACHA and ACUHO-I in the next few days. So.